Welcome to the Stronger Together podcast brought to you by Sandpoint Strength and Conditioning. I'm your coach, Kenny Marquardt. Today, I am joined again by Sarah Adair, the owner of Revival Wellness here in Sandpoint and in Hayden. Today, we're going to talk all things women's hormone and women's health and how to get a new lease on life as you start to feel things change and maybe feel like you are not yourself any longer. So if that sounds like you, or maybe it sounds like your spouse, and be careful with introducing that idea to them. Listen in. All right. Sarah, welcome back.
Yes.
All right. Today we're going to talk about the ladies. We're going to give them a chance to hear all that you have to divulge. And I'm excited for this just because I've seen the effects secondhand. I've seen it with so many women in the gym. And yeah, it's just been awesome. So
Good.
I think, I think we talked about this before, but I think maybe the first time you were on. But just the fact that it was such a neglected party in this idea that hormone replacement therapy was a good option for them, and just again seeing the positive effects in their lives and in their spouses' lives and their family members' lives has been so awesome. It's just been great. So
Cool.
Let's start. Well, where do you want to start? Should we start talking about just panels? What should be on a panel for people, and talk about reference ranges and whatnot? Or
Yeah, for sure.
where do you want to go? Okay, like I said before we got on, this is this. I'm not even going to pretend. So for men, I can at least I can play the game. I can talk to things.
Yeah.
This is different for me. So where do you want to go? Panels.
So we can talk about the initial panel. So much like we do for men when we get somebody who's getting freshly started on hormones, like haven't been on them period, or it's been a lapse in time. We like to get that comprehensive panel, which of course includes the sex hormones. So for the major ones for women, progesterone, estrogen, testosterone. So those are the main players. We also like to look at the thyroid, just like we do with men. That interplays quite a bit. And then some adrenal function labs like cortisol, that kind of stuff. We have done a little tweaking with our initial panels recently to include insulin levels, A1C, and some iron and ferritin levels. Iron and ferritin are a little bit more important as far as women with menstruation and a common complaint of fatigue. So that's something that we look into, but it also can be affected in men that are on testosterone, so we are adding those in there too. So, but of course, along with those is your liver, kidney function, your blood cell counts. Vitamin D is also very important, and then some vitamin B levels. So pretty good, initial extensive panel. Now, and then with follow-ups, then we're more gearing it towards based on their treatment plan. So of course their sex hormones, if we've started them on thyroid supplement, then looking at that, that kind of stuff. If we've started them on a program to reduce their insulin levels, then repeating that, see how we're doing with progress.
So the symphony, like the orchestra, has got to be all in unison, and that's as much as we are probably going to end up talking about the sex hormones, like there are a lot of other things at play that are important to explore as well.
Yeah. And women have just, a few more players in the game. So as far as estrogen, progesterone, now men have those to a smaller degree, but women, that's their primary, those three.
Yeah. When should women start getting these panels done?
Good question. So I think a good indicator would be if there's a significant change in your menstruation. So whether that's starting to skip periods, because that's a pretty classic sign of menopause, especially in the later decades of life. Now, you can have a skipped period here and there, and that's completely normal. But if it becomes a more consistent pattern, that can be a sign of perimenopause creeping in. But it's usually associated with other symptoms too. So lack of motivation, brain fog, low libido, fatigue, sleep disturbance, physical changes like skin condition, dryness in your skin. You can have vaginal symptoms like vaginal dryness. Even symptoms of urinary tract infections can be signs of low estrogen. So it's usually, and it can be hard because for women and men, we start producing testosterone in our earlier decades, 20s, 30s the most common. But now that we're seeing all these effects, environmental stuff on our hormones, women can start that perimenopausal phase much earlier, like in their 30s sometimes. And especially, there can be some, a familial component to that. Like, oh, my grandma had early menopause, so did my mother, and so am I. But also, those environmental factors can kind of accelerate that too. So traditionally, it was like 40s, 50s, but certainly I'm starting to see it a little bit younger.
Yeah.
And go into the being able to sustain pregnancies with low progesterone. Women are miscarrying a little bit more frequently, and I think there's multiple factors to that, but progesterone is a big part of that, and so more women are needing progesterone to sustain pregnancies even.
Interesting.
Yeah.
We touched on this a little bit last time, and I'm not sure I want to open the door yet, but as far as like why this is all happening, I guess it's worth asking. Like, what's the, because I want to reverse back to a little bit some of the stuff you just mentioned, but
Sure.
do you have indications on why this stuff's happening? Why we're starting to see these declines decades earlier than we used to?
I mean, a lot of that points to the endocrine disruptors of our everyday life, whether it's the air, the exposures we breathe, the toxins we're subject to every day, and products that we use, our food supply, lack of nutrients in that particularly, but also the chemicals that's probably in our dirt and our meats. So it's a big combination of factors. I wouldn't say it's one thing versus another, but like one factor. But also, too long ago spoke with a nurse midwife who is seeing the rise in miscarriages, and there was a correlation a little bit with those that received the vaccine with the increased rates of miscarriage.
Interesting.
So there's factors like that contribute as well.
Got it.
History of birth control use can affect hormones because they're typically synthetic, and so that can cause a change in your natural hormone balance as well. So depending on when you were started on that, how long you were on them, the form of birth control.
I see.
Okay. So yeah, those are the factors we consider when we're talking with any female patient, kind of regardless of of what potentially caused it. We're trying to help them feel symptomatically better, but also, systemic. Those positive downstream positive effects for their overall health, and catching them in that really important phase of perimenopause when these things should be starting to be replaced.
Yeah.
Yeah.
And then the more broad or universal trending, it's not as though it's something that somebody's like doing necessarily. Like, these are just environmental, like you said, environmental factors, but maybe legitimately or literally environmental. And maybe it's just like, this is just our day and age. And so it's not
Sure.
as though someone's got an exposure to, like, this seems like more and more and more women are just seeing a decline happening earlier. And like, it's not as though you should ignore this because you live healthily.
Right.
It's just, we in North Idaho, we're typically eating more like natural organic foods. I think we tend to be a little bit more earthy, and it's still like lots of people are having this thing. So point being, it's probably good to just keep an eye on regardless of.
Well, and it's something our body naturally does. Given that you're going to live that length of time, it's a natural process. So it's not something you did or didn't do. You just continued to live, and every woman will go, again, assuming you hit that age in your life, will go through menopause.
Yeah.
Same with men, you will hit andropause, and so just helping yourself feel better.
Yeah. So yes, though we're designed to reproduce and get out of the way, it's probably nice to just keep living for a little while longer.
Simplistically, we're meant to reproduce, and then your time here is done. So, and as we're living longer, these are things that we're learning in science and in medicine. So
Yeah.
So
chronologically, though, it's like that's not necessarily. I mean, do you have a general sense of when it's? I mean, I'm sure these are part of people's annual panels, but although, as we've talked before, sometimes a primary care provider are not as progressive or looking at some of these things. So, sorry to restate the question.
Yeah.
What age are you suggesting for people?
Yeah, no, that's true. And I hear that a lot, like when we're asking patients for labs, new patients that come over and like, yep, we'd like to look at your labs. And they're, oh yeah, it's really, they check these all, every year and they're typically, very basic labs, liver, kidney function, maybe an A1C, that kind of stuff. But very rarely, unless the patient asks specifically, do I see hormones involved or vitamin D levels or insulin levels, that kind of stuff. So I think, tracking that annually, and especially if you start to notice symptoms, trends are helpful, but not necessary. But it can help the patient realize there is a correlation, especially when they get someone that can interpret more from a functional, that's a loose term, but a functional medicine standpoint versus standard labs and saying you're normal, but that doesn't quite correlate with how you're feeling.
Yeah, which as a reverse engineering of the things you mentioned as signs that somebody might want to be doing these, thinking about all those things are not making life a lot more fun to experience. That was a pretty long list of things that would be affected by some of these things that can be improved. So kind of the same culturally. I was having this conversation with somebody else earlier about how culturally it was a generation before us, like just kind of bite down and muscle through. And like, this is just what you have to experience to be both a man or a woman, like midlife crisis, you've fallen apart and that's just what it is.
That is life, right?
Yeah.
And unfortunately, a lot of people get told that, a lot of women. And I think the waters were a little bit muddied for us. There was the Women's Health Initiative, which was a large study that they did using synthetic hormones that they ultimately ended up stopping the study and they still published the reports because of, injuries obtained, stroke, heart attack, death, that kind of stuff with these women and the synthetic hormones. So that information was out there. Doctors stopped prescribing them, not looking into alternatives, and just, there was a blanket, hormones are bad, like all hormones are terrible. So, and that information affected several decades until, more recently, thankfully, we're starting to see that bioidentical hormones do not pose that same risk and that they're actually very safe and effective for preventing a lot of those diseases and injuries. And so that will take more time, of course, but there's a couple of decades of women that we lost to treat in that time frame because of that bad information.
And was that related to or a separate incidence of there was breast cancer concerns as well, right?
Correct.
Like that was in the 80s or 90s, I believe that study was?
Yep, part of that too. Yep.
So, yeah. But like as I mentioned as we got going, it seems to be that those positions seem to be not evolving, but they're just being plain observed that was just wrong. So
yeah, it was there was still some positive information from that study, so I think that needs to be accounted for. But with more and more people on bioidentical, now more studies are being done to show their safety. And so as more and more studies are completed and that information is dispersed, just like the transverse study for men with TRT recently, more and more information out there spreading those good studies. So doctors have access to them. Obviously, that's important, but so does the general public looking for information. And it's just going to take time for medicine to catch up. Traditional systems, institutions to start reteaching that in the programs. But
yeah, sure, it's a generational thing again, where it's holy crap, we got to wash some of these people out.
Yeah, well, and that's the evolution of science, right? Things change, more studies come out, but
yeah.
And
to be the counterpoint, sometimes that's not the worst thing, where it's like, okay, let's actually see the long tail of what happens here. But somewhere in the middle is probably the right answer. Mm-hmm. You mentioned a newer study on the men's. You said something about transverse study on men.
The transverse study, it was published in the New England Journal of Medicine, I believe 2 summers ago. It was a large study, several thousand men using testosterone, and showed that there was actually no increased risk of cardiovascular disease, blood clots, that kind of stuff. And so the following February, so it must have been 2 years ago, so last year, they took the FDA warning off testosterone medication itself
Oh, wow.
regarding that.
Interesting.
Yeah.
And
And so
that,
the
yeah,
same
sorry.
holds true for women then, right?
Yeah.
There's low risk, yeah.
Perfect.
If
Yeah,
done
makes sense.
if done correctly and safely, obviously.
Sure, sure. Okay, do you want to talk reference ranges on some of these things? I know we could talk with all the markers you just mentioned, like that would be impossible to go through all of them, but do you want to talk about some of the more
Yeah, more common.
popular ones? Yeah.
Yeah. So with women's hormones specifically, reference ranges, women and it can be a little bit more difficult with women when we're in this perimenopausal phase. What classically happens, testosterone is one of the first hormones that starts to decline. And again, we can notice that as early in as our 20s, but more commonly, I say 30s is what I see clinically. So that's usually the first to go. And then once periods start becoming irregular, and even before that, progesterone levels start to decline. And then at some point, estrogen levels start to decline. And that's more, there's a more steady decline of estrogen as we get closer and closer to official menopause. But in between, there can be spikes in estrogen, and they can be very unpredictable and hard sometimes to balance. So oftentimes I'm treating with testosterone and progesterone, and then sometimes needing estrogen on top of that. It very much depends on the woman, what symptoms they're having, and then of course labs are helping to guide me in that too. And so that's why sometimes women's regimens are different. Of course, we treat everybody individually, but they have their own treatment plan, but theirs can be a little bit more different in comparison. If you were to, go talk to, a man to compare their treatments, it's usually off just by a little bit. Women's can be different. So
Was that a 28-day cycle being part of the problem, or is there a lot more to that? Just being that it's on a 28-day cycle of testosterone, estrogen, like hormone fluctuations, and a man's on 24-hour. Is that a big part of it, or is there a lot more to it than that?
Yeah, so I mean, when women are cycling, right, their hormones change roughly every 28 days. Some women's cycles can be a little bit shorter, a little bit longer. In perimenopause, those cycles change. So it could be that now my cycle, like I totally skipped a period and now my cycles are every 48 days, or just completely unpredictable at all. And so, trying to predict those fluctuations in what's traditionally normal can be very difficult.
And so there is a protocol or an ideal testing window for females.
Yes.
Being treated. Probably both, I guess, but for men, it's sorry, trying to use what I know about the men.
Men don't have these monthly cycles, and so they're testing. There's usually not a timing issue at all.
Before treatment, right? But after treatment begins, they should be testing at the long end of their.
Yeah, ideally, kind of in their trough. Now it
Yeah.
depends on what your dosing is. So if you are injecting just once a week, then I want to catch you towards the end of that week. If you're injecting daily, you're not going to have those fluctuations, and so we can check your blood really anytime.
Yeah.
If you're injecting 2 to 3 times a week, I'd like to check you kind of in that trough. So it depends, sometimes on that dosing regimen too.
Sorry, okay, I diverted you, but then for fresh out of the gate, no treatment, kind of whenever. When
For women,
treatment begins. Yeah, sorry, I was going down the men thing.
Yeah.
That's how I diverted us, but then back to the women's side. Sorry.
Yeah, so for women, if you're still regularly cycling, we like to catch you in a very specific phase of your cycle, and that's usually days 19, 20, or 21, because that gives me the best window to see if there's any imbalance. And it's typically what I'm looking at is there an imbalance between your progesterone and estrogen ratios. And there typically is when you're into that perimenopausal phase. It's usually estrogen can be pretty good, still a great level, but the progesterone is low, and along with that is usually testosterone. So I'm checking those levels even initially and in the repeat cycle to make sure I'm dosing appropriately to balance that estrogen and progesterone. Yeah. Because that's typically what starts to cause the symptoms of perimenopause is that drop in testosterone, and then the drop in the progesterone. You essentially become estrogen dominant.
Mm-hmm. So it's actually the imbalance. Is it more the imbalance than the levels itself? Or? Yeah, got it.
Imbalance, right. And so our goal is to, when we're medicating, we're balancing these within a certain ratio. And so, target numbers for women can be a little bit different because I'm more focused on how we're balancing you.
Yeah, okay.
Yeah.
So that was kind of submarines my next question, which was what are the reference ranges for testosterone and progesterone?
Yeah.
But what do we got? What do you think?
Yeah, so estrogen and progesterone can be a little bit different. Depends on the women, depends on what phase of perimenopause, menopause they're in, that kind of thing. Testosterone, generally across the board, I would say what I see clinically, most women respond really well with a testosterone roughly between 1 to 200. So it's about a tenth, in general, it's about a tenth of what men do, right? So if most men are feeling pretty good around 1,000, 1,200, so women would be 100 to 200.
Yeah, and that's total. Is there free? Is
Total.
The ratio ranging similar?
Yeah, it's similar. Obviously, with men tend to feel good between 25, 30. Women, they're free. They tend to feel good around 3 to 6.
And that's all the same kind of like sex hormone binding globulin stuff.
Yeah.
That's gonna make that
determine
change.
that free. Mm-hmm.
Is that as impactful? Like we talked with men stuff that's the free is really the important number. I imagine the same with women.
Yeah, absolutely. So, with kind of smaller, more narrow windows, if a woman, just like a man, woman has a higher sex hormone binding globulin and it doesn't allow for more free, they may have a higher testosterone level. Right? They may go, oh my God, my testosterone's 300 now. Well, but your free is good because your sex hormone binding globulin's elevated, right?
And then that ratio probably pertains to their estrogen. I mean, is that so? With men, it's a compensatory. Well, not maybe, but it's the estrogen levels will more than likely rise as a compensation for the elevation in testosterone. Is that same mechanisms in women?
Yes, okay. But I don't see it nearly to the degree as with men.
Because dosing is smaller, because it's
we don't aromatize as much. Yeah.
Oh, okay.
Yeah.
Got it.
Mm-hmm.
Okay. So, I mean, this is such an obvious dumb thing, but like, I think other people out there that think women should assume not have testosterone. You know what I mean? Like, is that something? Okay, that seems like something I kind of would have.
We hear it quite a bit. I mean, I hear a mix. A lot of people that come to us have already kind of done a little bit of their own research. And so when we talk to women about testosterone, there's very few times that they're like, what do you mean? That's not the kind of care I'm looking for.
Yeah.
Nope.
Right.
This is a hormone your body makes too. As you can see on your lab test, you're still making some. So, but it's not optimal like it can be. And it's the same conversation. Testosterone has, just like men, has a lot of effects throughout the system. Your brain health, your mental health, anxiety, it can reduce. It can help with periods too, actually. It helps us maintain our muscle mass, helps with libido, helps with our vaginal health, helps with our bones, all the things, joints, all that kind of stuff. So, when we educate them about that and that we're not introducing astronomical amounts, it's small amounts, not in the ratios that men need, there's an understanding there. So, but I also do hear patients coming from their other providers and hearing you absolutely don't need testosterone. That's, crazy to think kind of stuff. But a lot of women feel so much better on it.
And to again, call out the obvious or restate the obvious, but they're not growing beards and putting on. I mean, that's a facetious exaggeration, but at the same time, that's assuming that they're even with the men, we talked about this the first or second maybe podcast, but you see a body that's the image is the freak bodybuilder. Women have the same there are those same kind of, I probably shouldn't call them freaks because they whatever, but in any event, that's not what's going to happen if you get on whatever dose of testosterone we're going to talk about here in a second.
Are those women requiring higher amounts of testosterone? Yeah. Is that the average woman? No.
Yeah, that's not an overnight you start injecting testosterone and you lift a weight and all of a sudden that's not how this works.
No.
And in fact, those women and men work incredibly hard to work to get into that kind of physique.
Yes.
And they would be very annoyed if you thought it was just a very small amount of testosterone.
No.
And a little bit of lifting of weights that got
No. Yeah. Very true.
I say freaks, by the way, with all the due love and respect, because I've worked with some bodybuilders and they are kind of freaks in their own way. It's like they're just nerds, and
they're impressive.
They're athletes in their own right for sure.
Yes.
Okay, sorry, diversion. So, since we're on the subject, like we kind of got in here, what is a dosing regimen then that makes sense? And I realize, again, we're speaking in universals that are impossible to talk about for an entire, but like it's obviously, so last time I think we did talk about some starting doses for men where it's like in the 100 a week of testosterone cypionate, 2 or 3 times a week inject. Like there's a difference here for females. What was that? How different is it?
So typically it depends on, of course, the patient. On average, for a woman that's in their 30s, 40s, early 50s, around 10 milligrams a week, give or take a little buffer on either side, tends to work for most. Some require less milligrams a week, depending on if maybe they had a hypersensitivity with acne when they were younger. So I will start them at a lower dose just to kind of test how their body reacts to it, and then titrate them up to, whatever they're feeling well, just like a man.
Same compound? Sorry to interrupt you, but same compound?
Same compound, yes. Women's testosterone injectable, there's a little bit of a difference in that it comes at a fraction of the concentration. So men's concentration is 200 milligrams per milliliter. That's in their vials. Women's is 50 milligrams per ml. And so now, could they use the commercial product? Yes. It's a very, very, very small dosing. And so I do like to use the compounded concentration just because it's easier to draw and that kind of thing, get accurate dosing.
Wait, why is there a difference? Sorry, that you referred to as like the commercial. What is the difference there, and why is that?
So compounded versus commercial?
Well,
product?
sorry, yeah, you said so. Is there not a more diluted, which is maybe not the right word, but more diluted form of that that's commercially available? Is there an extra step that has to happen here?
Yeah. So testosterone injectable, manufactured, a commercial meaning a major compounding.
Yeah, it's a
manufacturer, so like Wilshire, Hikma, there's many. It's a across the board standard concentration of 200 milligrams per ml. I'm not aware of any commercial manufacturer that's making women's concentration other than compounding pharmacies. So compounding pharmacies are making the women's concentration. And so they typically, the commercial product is compounded in grapes or cottonseed oil. Compounding pharmacies will use different oil bases. And sometimes, if there's a sensitivity in men with cottonseed, I'll switch them to a different oil. So I do like to use, though, the more women-specific compounded concentration for more accuracy.
Got it. Interesting.
Yeah.
Okay.
Mm-hmm. But it's all still the same. It's the same bioidentical testosterone itself. It's just the compounding pharmacy makes it there in their compounding pharmacy, and then they ship it.
Okay.
Yep.
And injecting, did you mention that once or twice a week? For women?
Most women, it's twice a week. Mm-hmm. Okay. Yeah. And because we don't require higher doses, most women do fine with twice a week.
Yeah.
Mm-hmm.
And now I've spoken with a lot of women over the last couple of years about this, which is great. Like the fact that they're open. Again, this is not my bailiwick. I can talk about the men's stuff a little bit better because I'm a man. But the fact that there are a lot of primary care physicians who are, even if they are more progressive in this, that they will prescribe exogenous testosterone for women. They will do it in the form of a cream or a pellet. Now we're talking injectables for you, right?
Yeah. So if they're now, I can't say, to be honest with you, that I know of a clinic that takes insurance, like in your traditional, GP office, general practitioner office. You go in and they are accepting insurance, managing everything else. That they would also do pellets. As far as I'm aware, that it is never covered under insurance.
Sorry to cut you off, but I wasn't aware that women's testosterone therapy was covered in insurance. Period.
often not.
Yeah.
Unless they're getting prescribed, possibly they could be if they're getting prescribed a commercial product. So something that's covered by most insurance companies as readily available by a commercial manufacturer. So going back to some compounding or a commercial product like Hikma or Wilshire, they do make 1 ml vials that some women do use that for their injection. So possibly that would be covered under insurance. Most any product that's compounded, typically insurance will not cover. There are some potential exceptions like with HSA accounts and that kind of stuff. But
yeah, so the idea though being that so the pellet is a quarterly thing. So I guess what I was going to ask you, and I kind of let it in there, but like the drawbacks of those two mechanisms versus just injections, and why. So curiosity on why a lot of primary care don't do injections, which I've heard that a lot, is that a lot more women are on a cream or on a pellet, and a lot fewer are on injection. So I'd like to talk like pros and cons, if there are pros on the. Well, there probably are pros on the cream and the pellet, and then the
So pellets. I'll start with pellets. Some people do really, really good on pellets. They really like them. They're super convenient because you do have to just do them quarterly, which is kind of nice. Why I see more people getting away from pellets is because once those are inserted, they don't. Well, they shouldn't come out. Sometimes they do. They pop out, and so that's inconvenient for sure. There's a minor surgery involved in that with placing them. So some people have experienced pretty nasty infections regarding that with the insertion. But I would say the most common complaint I hear is, once those start to dissolve, you get this great rise in your testosterone. You're feeling great at this peak, right? And then you start to come right back down. And so throughout the year, you're doing this.
So every 90 days, you're done an every 90-day cycle intermixed with your potentially normally 28-day cycle. You're having your,
you're experiencing those peaks and troughs on top of maybe your monthly cycle. Yeah. So that doesn't sound great at all.
Yeah. And it's probably a harder target to acquire or harder thing to understand what's actually happening because testing those numbers becomes more difficult if you're only changing the variable once every 90 days and you try.
Well, you're supposed to collect labs in their peak, right? So roughly 4 weeks. So which, around that time, let's say you're not quite getting the effect, so then you have to maybe consider adding more in, or you're having unwanted side effects, and that is more difficult to manage because you don't go in and remove them. So it also makes it harder, I could imagine, potentially on the practitioner side to kind of manage some of that. Yeah. So creams, some people like and prefer and do very well on them. It depends. I've seen some women and men alike, when they've come in on a compounded cream from somewhere else, another clinician, historically they've been told to place it on skin areas that have low subcutaneous fatty tissue. So like wrists, behind your knees is a commonplace, inner thighs, that kind of stuff. Absorption rates drastically vary. A lot of people say, I don't notice the effects. It kind of correlates with their labs. They're not absorbing. And so some people get frustrated with the creams.
Is that interpersonal, like person to person, or depending?
Yeah.
Are there other factors at play there? I mean, is clothing like winter versus summer? No.
Depend. So if a person really wants to stay on a topical cream, then I will have them apply that medication as long as the dosing's not too high on genital skin. So this for men, apply it to your scrotum. For women, apply it to your external vaginal tissue. And that's because that tissue is highly absorbable and it's very vascular, and so the absorption is greatest there. And so it often requires much lower dosing, so you kind of have to be careful with that depending on what they're already on. Yeah. But some men, women alike, prefer the cream. Just, again, people with needles, if that's a complete aversion for them, then I totally get that. A potential downfall with it is it's daily, so if that's a daily routine for you is difficult, that can be something to consider. The other thing is there's a risk of transference. And so that also plays into why I have them apply it to their genital skin. If you're applying it to other parts of your body and then you're touching, let's say, even an animal. I have a vet that's like, yep, we were seeing all these crazy high numbers with testosterone. I'm like, what is going on? And then I finally put 2 and 2 together. So that's another That's another reason to apply it to the genital area. So that risk of exposure is hopefully only to your partner. Yeah. That risk is greatest within the first 2 hours of application. So if you apply it, have a normal routine, somewhat. You take a shower, you apply your stuff, get ready to go to work. You're absorbed it by the time you get to work, probably. So those are other factors with the other types of replacement.
Cool.
Yeah.
We're stretching into almost 40 minutes, but I would like to talk about those other numbers too, and like implications and treatments and stuff too. So if we can, I'm not trying to rush you, but I just want to say, acknowledge that we've been here for a while.
Yeah.
I'm going to go to what's next? Estrogen or progesterone? Yeah.
And so going back to that, those ranges, again, I'm trying to keep within a ratio. So of roughly a 2-to-1 ratio, roughly. So let's say a woman's estrogen is around 100, which is a kind of a good target number. And again, it's very dependent on each person. Then I would want their progesterone levels to be around 10 or more, depending on if they feel balanced.
Okay.
Yeah. So that's just kind of a rough. Women require those levels to be higher. And it's, again, very dependent. Some do better at slightly lower dosing. So with any hormone, we're going low and slow and increasing or adjusting based on how they're feeling.
Yeah.
Because just like men, if a woman's got too much estrogen too quickly, they can develop similar symptoms like breast tenderness, cramping, mood changes, that kind of thing. So I either need to up their progesterone to balance their estrogen or decrease their estrogen for a little bit to decrease those symptoms.
What other downside side effects, like where on the higher ranges? I mean, we talked about a little bit why somebody would want intervention because of those other negatives, but like what about too high? If somebody ends up too high, what's the downside?
It's usually related to an imbalance. So if you're estrogen dominant, you're going to have potentially some of those perimenopausal symptoms. So mood changes in your menstruation. You can even have lack of libido if it's too high. It's kind of the symptoms you would see in perimenopause. Yeah. So it more so relates to the imbalance versus a specific number, if that makes sense.
Yeah, okay. And so... Sorry, there are other numbers there. I guess the question I was going to say is like, this is a process still. We talked about that with men where it's like, this is probably not day one, you're getting on 100 milligrams a week and you're la-di-da, see you later. It's probably going to be a little bit of a, wait and see and adjust and wait and see and adjust and et cetera, et cetera. Yeah. It probably will change over a lifetime for quite a bit. So women, same thing, I'm assuming, and maybe even harder.
Yes. Yeah, I do like to tell my female patients, like this may take 3 to 6 months to find kind of your happy spot with your dosing, potentially less, potentially more. Unlike men, where we can typically, because there's typically just one component we're treating with testosterone, get them there a little bit faster. But sometimes it can take 6+ months for them too, just to notice some of the more overall effects.
Yeah.
Yeah.
So
same with women over time. Yeah.
Got it. Okay.
Especially the weight loss stuff. Yeah. Weight loss, the weight complaint with women with perimenopause, and it's usually, again, that lack of balance with estrogen and low testosterone, that tends to take more time for women to notice that than it does for men to get those benefits.
Yeah, interesting.
Which is frustrating, and I get that, but that's more of a long game.
Holy shit, welcome to my world. Jim, it's like, hold on a second. I know it didn't work this week, but we just can you give me at least like 9 or 10 more? We can talk about this. And then we can still adjust. Like, it's not well, you're speaking my language. Mm-hmm. Okay. Let's see, were there other reference ranges that we should have talked through or ratios or stuff that we didn't get into?
I do like to look at iron levels. And those have a less of a more narrow range, especially if we're starting them on hormones and there's still a little bit of complaint of some residual fatigue, and especially if they're still cycling or have a history of heavy menstruation, that kind of stuff, I'll check those levels. If it's required to, let's say they have low iron and low ferritin, which ferritin is your iron stores, then considering supplementing that for a short time and repeating it can help. Sometimes that can be complex because ferritins can be elevated in states of metabolic dysfunction. So if they have an elevated A1C and an insulin along with that, maybe addressing that instead of, supplementing might be what needs to happen. So it just kind of depends on what's going on. But we do like to look at those markers too, because low hormone levels, especially chronically over time, can result in insulin resistance, and which leads to weight gain and all of that. So it all interplays. And so insulin levels, I do like to see less than 10, ideally. So we're looking at that too, especially over time as we're balancing everything and hopefully keeping that where it should be.
No, that's oh my goodness, I should know this. Not the fasted insulin we're talking, because that would be under 100. We're probably under
Fasting.
that,
Yeah, insulin should be fasting. So you're talking about glucose.
Yeah, I'm sorry. Correct. Okay.
Yeah. And of course, when you're looking at metabolic dysfunction, and most people know it, diabetes comes to mind, we're looking at glucose, insulin, and your A1C.
Yeah.
So those all interplay.
Right. Got it. Okay.
Yeah.
You mentioned the iron and ferritin for men as well. Are you talking about a deficiency or whatever the opposite of deficiency is?
Yeah, occasionally, yeah. So
Surplus.
I don't see deficiencies as frequently as I do with women, because we menstruate. But I'd say a common misconception with men, I don't think I've ever heard it in women, is the need to donate blood while on testosterone. And if you do that chronically or frequently, you can dump your ferritin levels. And so if you're doing that frequently and you start to notice like, I'm feeling fatigued, I'm dragging, that kind of stuff, I will check their ferritin levels, and they're often low. And so we have to do replacement. So that's why I don't always encourage therapeutic phlebotomy while on testosterone. It's not a requirement.
So I was reading conflicting things on that where so the therapeutic phlebotomy would be as a treatment for high hematocrit, correct?
Correct.
And so the response that it was like whatever the hell the point was like, well, that actually is going to just cause it's going to bounce right back up and potentially
Correct.
even higher.
Yes.
Accurate,
So
or has that been your experience?
Yeah. So it can temporarily lower your blood levels roughly for a week's time or so.
Your hematocrit numbers?
Yeah.
Yeah, right.
And hematocrit numbers are multifactorial. There's several different things that can affect that level, make it low or high. Testosterone therapy can cause an elevated hematocrit because you're producing more red blood cells through erythropoiesis, but it doesn't necessarily it's not 100% the reason. Can it be? Yes, a contributing factor. Are you staying hydrated? Maybe we need to change your frequency so that spike in your erythropoiesis isn't so significant. So there's different ways to fix that other than phlebotomy. And when you do phlebotomy, like you just mentioned, your body's response is, I just lost a lot of blood. What is your body going to want to do?
Make more blood.
And so it's just a very temporary fix. So if somebody wants to donate blood, and they like to do that, by all means, donate blood. But I wouldn't suggest it really more than quarterly. Twice a year would be my preference, because again, you can dump your iron, your ferritin levels. Yeah.
So is the hematocrit issue similar with females? Do they have a same, or is it because of a menstruation cycle they do not? Well, I guess that wouldn't matter after menopause. So,
right, yeah. So that ferritin levels tend to stabilize in official menopause, I don't.
Though, sorry, does the elevated hematocrit happen Is that a female
Not
or
like
not?
not in women like I
Side
see
effect.
it with men. Yeah.
Got it.
And again, it's because our dosing is much lower.
Okay, cool.
Yeah.
Upsides of all this. I mean, I think we just like kind of skirted around the subject, but like women are feeling like they have a new lease on life from what I've talked to a lot of
Yeah.
people about.
Yeah. I think, of course, people want to feel good, obviously, and we are glad to help them with that. But a big part of our teaching with all this too is understanding how this impacts your health long term.
Mm-hmm.
So you know all these things, but you're maintaining your muscle mass, so you decrease your risk of osteoporosis. You decrease your risk of osteoporosis when you fall. It's not going to cause your death, you know, within a
Yep.
year, which those numbers are
Yeah.
unfortunately really high.
Yep.
You can live on your own comfortably, be more independent as you age because you're able to do these things still. Your cardiovascular health is better, your brain health is much better, your joints are much better, so also considering all the long-term benefits of therapy.
Yeah. And it's not, this is a gas on the fire type of a thing where it's going to help people re-engage with or feel better when they work out. And so
Yeah.
it's not a one size fits all, like this is the answer. If you get on testosterone, you will heal, you will develop thicker bones and you'll improve your muscle. I mean, some of that will happen for sure, but
Yes.
not nearly to the extent of if you do that and go back into the gym, which is a lot more fun when you don't feel like shit all the time.
Yeah. Well, and you're getting to see the results that
Sure.
you're working towards. I
Yeah.
hear that a lot. Like I'm in the gym 4 days a week and I'm doing cardio 3 days a week and I
Yeah.
keep gaining weight. Yeah, I get
Yep.
it. Yeah. Yeah. So yeah, getting kind of that love for life back, and it's awesome hearing my relationship with my partner is stronger. I want to play with my kids. I have the energy to do that. All that kind of stuff is fantastic.
Yeah. And almost like, I don't want to sound like, but like looking at a generation previous to say, holy shit, I watched my mom or parents go through this. Like, and I remember that, how they felt and how they looked and how they behaved. And I don't want anything to do with that. And like, that's a possibility. Like,
Yeah.
you can fix it. You can do that. You don't have
Yeah.
to experience that. And that's cool. I think the empowerment of what's possible through relatively minor interventions for people is like, it's really exciting. And that's what we do.
It is.
Like for what we do in the gym. It's like, holy shit, we've just actually told you can say yes to so many more things. But we're still just a tool. And same for you. It's like, you're a phenomenal tool that people can embrace and really gain, again, I think I said this before, but a new lease on life.
Yes.
Why not?
Yeah.
Cool. Well, we
Absolutely.
talk about this every time, but where can people find you, and what does it look like from there?
Yeah, so revivalwellnessclinic.com is our website, and there's access to booking appointments, free consultations through either location, so in our Sandpoint location and in our Hayden location. We're also on Instagram and Facebook, and then of course all that information's on the website too, with links to all that.
Perfect. And then does it say something on the site about the, 17 to 19 days for their timing of their consult, or should they do a consult and does that matter?
Yes, when we do the consultation, especially with women, we go through that with them so we know when to collect their labs. So yeah, that's discussed in that consultation. Yeah.
That's before they would sign up like that.
Before they sign up
that's
for
not a
labs,
consideration
yeah.
necessarily of the secondary part.
Yeah.
Cool. All right. Well, thank you very much.
Yeah,
Appreciate it.
always. Thanks for having me again. Look forward
Last
to the
time we
next
did this,
one.
I was approached by so many people who are just so thankful for you doing this and the
Oh, good.
education that they got. So yeah,
Good.
thanks from them as well.
Yeah, awesome. Thank you.
All right, Sarah.
We'll talk to you soon.
Have a good rest of your day.
Yeah, you too.
See ya.
See ya.
All right. Thank you for listening. As always, would be very excited to help you on your journey. Sarah and I mentioned, like, these interventions are complementary of each other, and one doesn't really work as well without the other. So if you speak and work with Sarah, you should come and work and speak with us. Vice versa. It's just a way to optimize and live a life you love for as long as you possibly can, which is at the end of the day, our goal for you. So reach out to me if you need help with your fitness, Kenny at sandpointstrength.com. And you already heard how to get a hold of Sarah. All right. See ya.